Okay, we're going to work through this case study of a 57-year-old man who's referred to the pulmonary function lab for increasing shortness of breath. He admits to having a chronic cough with production of thick white sputum, mainly upon awakening. The subject reports he quit smoking 3 months ago, and he averaged approximately 2 packs of cigarettes per day for 30 years. This is a 60-pack year history. His referring physician performed a pulse oximetry in the outpatient clinic and obtained readings of 90 to 91%. Complete pulmonary function studies with arterial blood gases were requested. So the questions we are trying to answer with this case study are, why is this patient so short of breath? And why is his SpO2 so low? Let's go on and take a look at our results here. So here we have our spirometry results. Remember, when we look at spirometry, the first thing we look at is our FEV1 to FVC ratio, which here they are indicating it with the FEV1%, same thing. And we see our patient has a 58% FEV1 FVC ratio. Remember, for obstructive diseases from our spirometry section, anything less than 70 suggests obstructive disease is present. So after we have identified that, we look at our FEV1, okay, and we see that that is 77% of predicted. Based on our GOLD COPD guidelines, this is a stage 2 or moderate obstructive disease for this patient. So the next thing we're going to look at is the percent change. And notice our FEV1 change is less than 200 milliliters, and we have less than a 12% change. So there's no significant response to our bronchodilator. So right now, we can say, based off our spirometry, our patient has a mild obstructive disease which is not responding to a bronchodilator. Those of us who work clinically in acute care, we've probably started to already decide that this patient has emphysema. But he does still have that productive cough, so we need to keep looking at all of our data before we make decisions. So next, let's look at our lung volumes. All right, the first thing we're going to look at is our FRC. Our FRC is 107%. Now that is obviously more than normal, more than predicted, but we don't consider that clinically significant until it gets above 120%. Once our FRC is above 120%, we say that patient has hyperinflation. So this patient's definitely heading that way, but they're not there yet. The next thing we're going to look at is our RV to TLC ratio. This is 37%, and normal would actually be 34%. So this tells us that the patient has some air trapping, and again, this correlates with what we've already been thinking as far as emphysema. It is important that you do look at your RV and TLC as well, just to make sure that you're not misinterpreting the data, but it all looks consistent with an obstructive disease, so we're okay. Next, let's look at our diffusing capacity. Okay, over here, our lower limit of normal was 19.5, and this patient had 16.7. So he is below our lower limit of normal, so he does have something affecting his diffusion. Then we're going to check it and make sure it's not due to anemia. So corrected with hemoglobin, look, it's exactly the same. So we know that hemoglobin is not the problem.